And Marianne Wamboldt is the president of the Family Process Institute, so it's a real pleasure to have her here. Let me tell you something else about her. Dr. Marianne, I will be reading her biography, so you will know a little bit about her in her own words. Dr. Marianne Wamboldt is a board-certified adult and adolescent psychiatrist and a professor of psychiatry at the University of Colorado. In her work as chair of psychiatry at the Children's Hospital in Colorado, she worked closely with pediatricians and family medicine practitioners to integrate mental health care for children into primary care clinics. She found through this work that having a more reliable and easy-to-use assessment of parent-child relationship problems would make it easier for medical care providers to identify children at risk and in need of early assessment and possible intervention. She has a background in behavioral genetics, as well as extensive research and clinical experience in understanding the role that family processes play in the outcome of children with a variety of physical or mental health challenges. So this promised to be a very interesting webinar and helpful, I think, to many clinicians. As I said, Dr. Wamboldt is the president of the Family Process Institute. I have gotten to know her and know how proficient she is and efficient, so I think you'll enjoy this webinar very much. It's all yours, Marianne.
Yeah, thank you very much, Vicki. I appreciate it. So how do I get to my slides? That's my one question. I could just click on them on my computer?
You just go to slideshow on your own PowerPoint at the top of your screen.
So here we are, everyone. I think welcome and thank you for joining me today. I'm really pretty excited about this. Well, if I can get my computer working. About this webinar and about being able to tell you a little bit more about a group that I've been working with for a long time, which was trying to get more definitions of relational processes into DSM-5, and now we're working with the World Health Organization to get them into the ICD-11 as well. So with that, let me start what the objectives will be today. So as part of this process that I'll back up and explain, but what I'd like you to get out of this particular webinar is what criteria did we choose to test as a parent-child relational problem for the DSM-5. We actually were fortunate to test that in the context of a DSM-5 field trial. So we have information about the DSM-5 diagnoses that the children in our study received and how parent-child relational problems related to those diagnoses. So we'll talk about that. I would really welcome your input as experts in the field, as family therapists, about whether these are the best criteria. This is a first pass at criteria. It's not necessarily the end-all and be-all. So I would really like to hear from you what seems to make clinical sense to you and what doesn't make sense. And then finally, I think all of this closes the loop with the new Affordable Care Act, that I think this is a huge opportunity for family therapists to get involved and partner with primary care providers, particularly to identify children at risk due to family factors and to provide early family interventions that might prevent children from developing more behavioral or medical problems. So we'll go through that a little bit. First, I'd like to acknowledge that this is not my work alone. I've been working with a relationship work group for over a decade now, chaired by David Reese. These are some of the other people that have been on the work group, and you probably will recognize a number of them as they're leaders in the field of family therapy, family research. We have, as a group, had a number of publications over the years, starting with back in 2002, David Reese looked at how relational disorders should be included into DSM-5. In 2003, talking about why relationship disorders were not included in DSM-4. By 2006, we had published a series of papers in Journal of Family Psychology talking about better guidance for research and practice with relationship disorders being identified as a need in DSM-5. Probably the best book that we published, if you're interested in documenting some of the basic science and clinical science behind relational processes and how they associate with mental disorders, is this book, Relational Processes and DSM-5. This was the outcome of a large conference that was held in Washington, D.C. back in 2003, where we brought together researchers from NIMH, other branches of NIMH, and around the country. And their work is represented in these chapters, but I think if you need a good reference for the basic science, this would be one place to go. Again, we were in the contemporary directions in psychopathology. Most recently, 2013, this very clinically relevant book came out. This book has chapters on not only parent-child relational problems, which I'm going to talk about today, but also child maltreatment, intimate partner distress and intimate partner violence, and all sorts of screening measures, structured interview assessments, etc. So very, very clinically relevant to what we're talking about. And then finally, the reason I'm giving this talk today is the most recent issue of Family Process, which is March of 2015, has a special issue on updates on all of the relational processes that were included in the DSM-5 and what we're hoping to get included in ICD-11. So this is a brief overview of one of those. Well, why should we look at parent-child relationships? I mean, I'm a child psychiatrist, so I primarily see children as my identified patient, if you will, and then very quickly get to know their families. And it's no surprise to any of you that caregiving relationships are one of the most significant environmental factors for children and for the development or the moderation of their mental health problems, as well as mediation. What's been exciting in most recent basic science is looking at the epigenetic effects of caregiving relationships. So epigenetics means what turns on or turns off the genes that we have. And once they're turned on or turned off, that part of the gene being turned on or turned off then gets passed on to future generations. So some very elegant animal models looking at mice, looking at good parents, which are defined in this model by those that lick their little mice pups very often and that gather them in a little nest and crouch over them and nurse them very frequently, versus not so good mothers in these mice who don't lick their offspring very often, who don't necessarily crouch over them as often or keep them as safe in their little nest. So by doing a lot of elegant experiments with offspring of the good mommy mice versus the not so good mommy mice and cross-fostering, Meany and his colleagues up in Canada were able to show that what actually happens with good parenting, if these mommy mice lick their offspring a lot, they actually turn on certain genes in those mice, even if they were genetically from the not so good mothers, that then got passed on so that when they became mothers, they showed better parenting because of that. So here at a very basic biologic level is a really lovely model to show that early parenting in particular can not only affect behavior but can affect parenting behavior for the next generation. So those of us family therapists who think about multi-generational passage of dynamics, of processes, etc., this might be one mechanism whereby some of those behaviors get passed on. So I think it's really very exciting work. Lorna Benjamin and her colleagues have been working on parent-child relationships and how people internalize their relationships with their key caregivers for decades, and have done some very elegant work showing that, again, no surprise, that if you were the lucky child to have a parent who was very nurturing and giving you autonomy and lots of positive feedback, you were more likely to internalize that into your working model of relationships. Whereas if you had a parent who was very critical or absent or neglectful, your working model of relationships that you internalized expects that from relationships and might call it to come out. So from a more clinical psychological approach, their work has shown that these parent-child relationships can exacerbate or even create psychopathology. All right. Many of us who work with children and parents, especially children that are basically pretty healthy and stable, and parents that are basically pretty healthy and stable, we see them because they're having a problem in their relationship. And some of this comes from the idea that you want to look at the goodness of fit between a child's temperament and the parent temperament And sometimes these temperaments, each of which in their own way is very healthy and normal, just don't match. So for example, you may have a very high activity parent who's used to running and being busy and being very active, and her very lovely child might be a more laid back, wanting to sit still, not liking to be pushed around very much. Neither of those is necessarily bad, unhealthy, or leading to pathology, but because the fit doesn't work, children in those types of relationships are particularly vulnerable because they're more vulnerable to the environment, and their developing brain is more sensitive to the caregiving environment. So there's been a nice study done by Hudjek et al. There showing that within healthy parents and healthy children, if the temperaments of the primary caregiver and child don't match, they are more likely to need some help managing the relationship, particularly in the first year or two. So this is an area, for example, those of you who want to be involved with primary care, pediatrics, or family medicine, to pick up these early parent-child dyads or families to help them, with the very little assistance for most families, understand how to deal with this difference in temperaments. You can set that child off on a much better trajectory. We know that even in very serious environments where there's neighborhood decline or violence in the neighborhood, where there's interparental violence, despite those very adverse circumstances, having a parent who is sensitive to the child really buffers that child from much of the adversity in those environments. So just like not so sensitive parenting might cause problems or lead to more problems, good parenting, sensitive parenting, can protect children from a whole variety of adversities. If you do have difficult early caregiving, there's a number of different studies that have shown that difficulties for that very young child, we're talking about children under the age of 3, can lead to changes in their brain development, can lead to changes in their stress hormone response, the hypothalamic cortisol system, can lead to changes in their ability to regulate their own emotions. And all of those things can become further risk factors for the development of mental health disorders in the child. So again, if we can pick up this early caregiving difficulty when it's still a small problem, an intervention at that point in time can really send a child off on a much healthier trajectory. As a behavioral geneticist, I'm very excited about the new research on genes and their effect. But what's really the most exciting is that genes only predict a small amount of behavior. And what we're really needing to understand is how do those specific genetic vulnerabilities or strengths interact with the environment to either lead to more problems or less problems. So for example, children with externalizing disorders, conduct disorder, very demanding, assertive, high energy children, it's been shown that most of that behavior is due to their genetics. Interestingly, the apple doesn't fall far from the tree, so their parents, if they're living with their biologic parents, probably also have a number of these traits. And what a number of groups have shown is that if you can intervene with the parents so that even though these children are pushing their buttons and a little bit more difficult to control, if they can back off on engaging in fights with them and have a little bit more consistent, regulated household, they can really decrease those behavioral difficulties in their children. Conversely, if they get into fights with them and into coercive negative cycles, that will increase their behavioral difficulties. Similarly, parental unresponsiveness, and what often happens in these families is, as you know, that the children can be very difficult, and for some time period the parent might be yelling at them or engaging in conflict, and at other time periods the parent is just not there. They're neglectful, they're ignoring the behavior, and the child might escalate their behavior to get the parent to respond. So both of these have been shown to be parenting styles that can make this genetic tendency to be more assertive and demanding either calm down and become a strength or increase into behavioral difficulties. Some very interesting new work coming out in internalizing disorders, so the anxiety, depressive kinds of disorders. This is just one that was recently published that shows that not only are there gene-environment interactions, so that, again, the genes for being neurotic are something that puts you at risk for developing an anxiety or depression disorder, but the environment has a lot to do with that. And in this study, they showed that there were also gender effects, so that if there's a lot of mother-daughter hostility, the daughters are more likely to have depression over and above the shared genetic risk factors for depression. But if there's mother-son hostility, that does not necessarily increase depression in the sons. So fascinating new work, and I think it's an exciting time to be understanding how mental health problems develop. But one of the things we really need to move this field forward and to really gain a very prominent role again in the whole delivery of health care and mental health care is a more reliable and widely used measure of parent-child relationships, so that we can really push the research forward to clarify where and how these relationships can either improve or exacerbate problems in children. And that research then should validate what so many of us do and know clinically, working with these kids and their families, that changing the way parents relate to their children can often have enormous effects on how the children develop. So there are three main categories that are usually assessed when you're looking at a parent-child relationship. The behavioral quality of the interaction, the affective tone of the interaction, is it hostile, is it supportive, is it positive, negative, and the psychological involvement or investment in the interaction. Yeah, so some examples, there have been many groups trying to work on this problem. It's not a new invention. It's a very tricky issue because of differences in developmental needs of children of different ages, as well as cultural differences across countries and even within socioeconomic diversity. It's very tricky. So I'm just going to give you a few of these examples. The Parent-Infant Relationship Global Assessment Scale came out of the work of the 0 to 3 consortium, which, as it states, is really focused on helping understand mental health in 0 to 3-year-olds. They have their own diagnostic system that has a lovely relationship axis in it with 6 different types of potential relationship styles, some of which are problematic and some are not. And their peer gas is really based on the expanding that into more of a continuous scale of 0 being very dismal relational interactions and 100 being optimal, and then anchors of helping people locate that infant in their caregiving relationships in between there. The group for the advancement of psychiatry back in 1996, many of the people on that committee at the time were very involved in trying to get relational disorders into DSM-4. Part of their difficulty was agreeing on what were relational disorders at that time, what examples should go into DSM-4, and they instead decided it would be better to do a similar global assessment of relational functioning. So there's a GARF scale that was in the DSM-4 TR as an additional appendix, and many of us have used that clinically. And again, this one is more looking at the whole family functioning. It's not specific to dyadic functioning, but it does give you a measure of the safety and the connectedness of the family. And then the emotional availability scales are really widely used in many, many countries across the world, which is one reason why I like them. They take up on the behavioral component of the relationship, but they also have attachment scales. And what's very nice about this work is it looks at what both the parent and the child bring to the relationship and see it truly as an interaction, that one is influencing the other, that it's not just a one-way interaction. But these are all very different scales and have limited reliability across ages and across different samples right now. The current definition used in DSM-4 is this. This category should be used when the focus of clinical attention is a pattern of interaction between parent and child. They give a few examples. That's associated with clinically significant impairment in the individual or family functioning, or the development of clinically significant symptoms in parents or child. When I took this definition into the pediatric clinic where I consult and where I teach pediatric residents how to deal with mental health issues in children and families, they found this either applicable to every single parent and child dyad that they saw or to none. And it was very difficult to help them sort out whether a child who's very autistic and not very warm or cuddly and a parent that's distraught about that, whether that should be a parent-child relational problem or really more appropriately diagnosed as a child with autism and a parent adjusting to that child. So it doesn't help you anchor things enough in a medical model, and thus it doesn't get used very much at this point and just fell to the bottom of their list. So in working in that clinic and working with the relational processes work group, we really started thinking about, is there a way to kind of get a checklist, even though that has a bad connotation in DSM for many of us, but the nice thing about a standardized assessment or checklist, if you will, is it does fit into a medical model format. So it's a much easier thing to train a pediatric resident. These are the things you want to assess between that parent and child that will tell you whether the relationship needs help in addition to whatever you're treating the child for. Or a beginning psychiatry resident, a beginning psychology intern. In many of our training programs these days, the family systems approach is not necessarily taught. And at least for psychiatry residents, there are innumerable requirements from the boards that sanction training programs of what they have to learn and what they don't have to learn. So people are so focused on what they have to learn that mostly they are taught to the DSM-5. I think that's true to lesser degrees, but still true in many psychology programs and many social work programs. So the marriage and family therapy programs, you folks have an advantage in that way, but for those of us who teach other healthcare providers, having a more standardized assessment would also make it more legitimate, but it enables better teaching. And one of our goals from the Relational Processes Group was to get better standardized definitions of these relational problems into DSM-5 so that we can both code them if that's the problem that we're dealing with our clients or patients, but we could also teach younger clinicians how to use them. So we were fortunate enough to be one of the sites, fortunate or unfortunate as the case may be. It ended up to be a lot of work, but the reason I agreed to do a DSM-5 field trial at our site was that I wanted to see whether we could embed a parent-child relationship problem within the standard field trial of DSM-5 and compare it to some of these other disorders. So my bias as a family systems trained child psychiatrist was that it's probably easier and better to define the relational problems for a child than to do these checklists for these other, quote, Axis 1 types of categories. But I wanted to show it in a way that others could believe it. So at Colorado, what the DSM-5 group gave us to test was something called disruptive mood dysregulation disorder. For those of you who don't know this, it is basically a description of an irritable or disgruntled child who periodically has major temper tantrums above and beyond what you'd expect for their age. It was put in really as a pushback to diagnosing these children with bipolar disorder, but it's an interesting set of concepts. New definitions for major depression, another kind of internalizing disorder called mixed anxiety and depression disorder, PTSD in children, and conduct disorder. So the way that the DSM-5 field trials worked were that symptomatic patients were recruited from all of our services. At the time, I was chair of child psychiatry at the University of Colorado and at the Children's Hospital in Colorado. So we have inpatient services, day treatment services, and all sorts of outpatient clinics. Any one of our patients who were currently symptomatic was eligible to participate. The patient, and they had to pick a primary caregiver, would have 2 interviews within 2 weeks with 2 different clinicians. And the clinician may or may not be new to the patient. So it may be somebody they had already been seeing on one of our services, or it may be somebody that they had never seen before. We had pretty large participation from our child psychiatry trainees, our child psychiatry faculty, and psychology interns, and 6 master's level clinicians. Unfortunately, in our program, we don't have any marriage and family therapists. It would have been interesting to involve them, but we have excellent social work, master's level and social work clinicians. The clinicians in our group were primarily female, primarily Caucasian. That fits in with the demographics of Colorado to some degree. And the mean years in practice were about 7. The DSM-5 staff came and gave training for about a morning. I think it was a 4 to 5 hour training to all the clinicians for what the new criteria were for these disorders that were being tested. And then parents and any children over the age of 10 would fill out self-report measures, which were scored, and the results were given to the clinicians before they assessed the child. And the clinicians could do whatever assessment they choose, and then they would complete diagnostic criteria. So on top of that, we decided to add this component of the Parent-Child Relational Problem field trial. And this was also IRB approved, and the child and their parent could choose whether they wanted to do this additional study or not. And about 2/3 of those eligible did agree to participate, and they were not statistically different than the other participants. And for this, it was very similar. They attended 2 additional interviews with 2 different clinicians within a 2-week period. And prior to each visit, the parent and child, children over 10, filled out questionnaires, which the clinicians were able to review. And then the clinicians performed a clinical interview of their choosing and filled out the criteria for a parent-child relational problem. So again, pretty much identical to the DSM-5 field trial. These are the criteria we tested. So these are new criteria, and they were developed with the whole relational work group that I discussed. They were also vetted internationally, and I'll come back to that. But at this point, we did not have the international additions in here. But again, you have to consider the developmental needs of the child. So a 3-year-old needs more protection and supervision than a 12-year-old. You have to consider the socio-cultural context. So a child living in lily-white suburbs where there's very little traffic might need less supervision than a child living in urban Denver where there's not only traffic but a lot of other dangers on the streets. So you assume you have to understand that context, and then you needed at least 1 criterion from A and 2 criterion from B. Criterion A was really getting at, is either the child or the parent or a clinician working with them thinking that they are dissatisfied or distressed more days than not during the past month. So all parents and children have cycles in their relationships where they're having good days or bad days, but to be distressed more days than not for a whole month, we thought would meet a level over and above, at least it's something significant that you'd want to pay attention to. So this could be either the parent or child saying they're very unhappy with the relationship, for children thinking about running away, for parents thinking about relinquishing care, and or any of them, the parent, child, or clinician, thinking that they might need professional help. And I want to just state that although we're saying parent, it really means primary caregiver. And in our clinic, we had a lot of primary kin caregivers, grandparents primarily, who would have been the primary caregiver for the child. And that number 3, although it sounds rather extreme, for these grandparents, that often came up as something that they were considering. Criterion B is there had to be significant impact on the relationship with 2 categories, behavioral, cognitive, or affective. At least 2 of those areas had to be affected. And we spelled out a number of ways that you could have symptoms behaviorally. So they could be conflict resolution difficulties, under-involvement, over-involvement. We actually had definitions for what conflict resolution difficulties would look like. So escalation of negative behavior into arguments or fights, or pervasive withdrawal so that you couldn't resolve conflict at all. Excessive or inappropriate discipline, but not meeting criteria for child abuse, but things like being grounded for a month from everything because a child didn't want to eat their supper, would be an example of that. Or for the child, excessive or inappropriate altercations or threats towards the caregiver. Kids that would kick or bite or verbally threaten their parent. That was a conflict resolution difficulty. Under-involvement, so the caregiver-child relationship, parents might fail to socialize their child, have very poor limits, have very poor support for positive behaviors, or they don't monitor their child. Over-involvement, we see this in some of our kids who come in who are either academically or athletically very pressured, and when talking to them, sometimes the pressure is coming from the parent rather than something that the child wants to do. Interfering in children choosing their after-school activities, for example, for older kids, that might be something where over-involvement would come in. Cognitive symptoms could be, and this is modeled after a lot of the work done with couple distress, intimate adult partner distress, where there's a pattern of negative attributions. So the mother might see that if a child breaks a cup at the dinner table, it falls off the table, that it's because that child voluntarily threw it off the table because they're a nasty child and they always do this. This is a negative attribution. Conversely, if the child does something positive, like they clear the dishes, the mother might say something like, well, they just want to get something. I'm wondering whether they want to be rewarded, or they did it by accident, or something else. And it can go both ways. Children can perceive their parents this way too, that if a mother sets a limit on a child, that her son might think it's because she's a nasty, mean mother who always tries to cause him trouble. Or if she's nice and decides to take him to a movie, he might think this is really because she doesn't, she's wanting me to do something, or this is an accident. She's not usually like that. And then finally, it could be affective symptoms. So either the parent or the child can have marked feelings of anger or contempt towards each other, or apathy or sadness. So again, those were the criteria we tested. So distress, and then at least 2 of these other symptoms. In the process, the parents wrote a 2-page narrative, which is based on the 5-minute speech sample. Please write your thoughts and feelings about your son or daughter. And the clinician got to read that before they met with the parent and child. And children over the age of 10 filled out 2 different instruments. One of them is called the parent bonding instrument, and it's an 8-item scale. The child rates either their mother or their father on how much care versus rejection they have, how much control versus autonomy they have. And again, it's the child's perception. This is not necessarily objective truth, but if a child perceives that the parent cares for them more than rejects them, then usually they have lower levels of mental health issues. If the child perceives that the parent's trying to control them more than giving them some freedom or autonomy, they usually have higher levels of psychopathology. They also filled out the perceived criticism measure, again based on the expressed emotion literature. So they would rate their father, how critical is your dad of you? How critical are you of dad? How upset does dad get if you criticize him? And how upset do you get if dad criticizes you? And this simple scale has been used in a number of studies that have predicted relapse in anxiety, depression, bipolar depression, and substance abuse problems, both with adults whose significant other rated them, or they rated their significant other, but also with children rating their parents. The clinicians were asked to assess the new criteria using questions that were used in the DSM-5 field trials, and they were asked to rate each item on this 5-point scale. And they're kind of basic utility questions. How helpful or useful were these? How much did these criteria help you decide what the primary diagnosis was? How much did this fit with patients you've seen in your routine clinical practice? And was this more clinically useful than the DSM-4 code of parent-child relational problem? So we, again, trained the clinicians. They got 1 hour of training on these new criteria. They were shown a semi-structured interview, which they could choose to use. Some of our earlier or younger trainees chose to do that because they really didn't know how to go about assessing a parent-child relationship, which was interesting. They saw what the parent and child filled out, and then they assessed the child however they wanted to. So the bottom line was that in a clinic, a child psychiatry clinic setting, both inpatient day treatment and outpatient, but symptomatic patients, about a third of the children that we were seeing were considered to have a parent-child relationship problem with the parent that came in with them. The interclass kappa for overall agreement between clinicians was 0.58, which indicates good test-retest reliability. I gave you the punchline, but I'm just going to back up and tell you a little bit about our samples. So we had over, I don't remember now, 132, I believe, parent-child dyads. You can see that in 79 of them, neither clinician thought there was a parent-child relationship problem. In 20 of them, one clinician thought there was and the other disagreed. And in 34, both clinicians agreed that they had a parent-child relational problem. None of the sociodemographics were significant, with the exception that parents who identified that their child was Hispanic were less likely to have a parent-child relational disorder than those who were non-Hispanic. And I don't want to make too much of that because we had a very small sample size for that, but we can talk about that a little bit in the discussion. But otherwise, there really were no differences, ethnic differences, living situations, age, and gender. The children over the age of 10, so we had 70 who were able to fill out these child report measures, actually had very good reliability over a 2-week period of an interclass correlations in the range of 0.7 up to 0.89, so in the good to very good range, which indicates that children, at least of this age, can pretty reliably rate their parents using the 2 measures that we used. And their measures made a difference. So if the child thought that their parent had higher care, they were less likely to have a parent-child relationship problem. If the child thought the parent was overprotective, they were more likely to have a parent-child relationship diagnosis. The criticism, whether the parent was critical of the child or the child of the parent, didn't really seem to matter, but the reaction to the criticism did matter. So either the parent got upset when they were criticized or the child got upset, that was also significantly associated with there being a parent-child relational problem. And this part is very interesting to me because we had all these other disorders that we were testing. And what you see here is that this disruptive mood dysregulation disorder, so children who are somewhat irritable or dysthymic at a low level much of the time, and then when something happens can just flip out and have a major temper tantrum. Not surprisingly in my mind, but interestingly, they had much higher rates of a parent-child relational problem diagnosed for children who also, by other clinicians, were diagnosed as having DMDD. And similarly, children diagnosed with conduct disorder, again, by 2 different clinicians and blinded to this assessment, they were more likely to have parent-child relational problems. So whether that means that the way the parent and child get along, that relationship is a key part of the pathophysiology of developing these disorders, which is one hypothesis, or more likely these are kids who might be tougher to parent based on some of the externalizing behavior disorder data I showed you before, and the parent has a trickier time parenting them, and it's easier to get in trouble with it. So these are particularly parent-child dyads that would need our help and intervention. Although there's no major trends in either major depression or anxiety or PTSD, at a clinical and research level, I'm really curious. Does depression with parent-child relational problem look different than depression in a child without a parent-child relational problem? And if we had good ways and reliable ways of diagnosing parent-child relational problems, I think this would make a lot more sense out of our current studies of treatments for childhood depression. Likewise for PTSD and anxiety depression disorders. So I still think it's very interesting covariate to look at. So just as in adults, if an adult has depression and they have a significant adult intimate partner and they're satisfied with that relationship, they can be treated with medication or individual therapy and they do fine. If they are in an intimate relationship and they're dissatisfied with that relationship, there's conflict, there's good evidence to say that if you don't treat the couple relationship, the depression is much harder to treat in that individual adult. So it could be similar for children, and we just have not tested it yet. And finally, the clinicians, by and large, thought that these new criteria were moderately to very helpful and better than the DSM-IV criteria. I just want to give you a sense of what some of the clinician comments were, because we did a qualitative study with this too. So the measure gives substance to the diagnosis. It's easy to use in making this diagnosis. Using the criteria ruled out a parent-child relational problem, according to the information. It helps to have pervasively used in the definition. So this particular person found it, even, I think this case was one of the children who had autism, and they were able, by going through carefully, to say, no, it's not a parent-child relational problem. The problem is the child has autism. So that was very helpful for them. This was from one of the psychiatry residents who had never done a relational assessment before, and he was blown away by how helpful this was and how useful it was to ask parents and children about some of these areas. And this was by somebody, again, who talked about, teasing apart if the child has a traumatic brain injury and they are, because of that, impulsive and inattentive, which could be a behavioral difficulty. You need to look at the whole picture. And interestingly, many of the comments came out that similar to the expressed emotion, that if the parent could see the child was ill or had some kind of disorder that made them vulnerable to problems, they were much less likely to be angry with them or apathetic or some of those other affective or cognitive distortions. So in those cases, you might have behavioral problems. They still might escalate into physical altercations, for example, but you didn't have the other criteria, so you wouldn't diagnose this as a relational problem. Overall, I will say, when I showed our clinicians these results after the study was completed, they were surprised. They really thought about 75% of our patients or clients would have been meeting criteria for parent-child relationship problems. So we had a lot of interesting comments and discussion about that, and we could bring that up in our question time if you'd like. Clinicians, it didn't matter their gender, their age, how long they had been working with families. None of that was significant to whether they did or did not give diagnosis of parent-child relationship problem or their ratings of how clinically useful it was. How does our kappa look? Our kappa that we got of 0.58 was really one of the higher kappas found in the DSM-5 field trials. If you look at all 15 adult and 8 child or adolescent diagnoses that were tested and that had an adequate sample size, we were on the very high edge of the good range, and most of the other disorders were lower than ours. So we think that you can reliably diagnose a parent-child relational disorder. So what did we learn? We learned children over than 10 can be given kind of screening measures, if you will, and they can fill them out reliably, and this might help us figure out how to identify kids who are having difficulties with their caregivers, say in a primary care setting. In an acute care setting, a psychiatric sample, a third were diagnosed as having parent-child relationship problems, and we'll talk about that more, but of those, children with this DMDD or conduct disorder were more likely to also have a parent-child relationship problem. So why is this important to us as family therapists, and what does the future hold? So as most of you have been following the news about the Affordable Care Act, one of the key components of that is to develop medical homes for patients where services can be integrated. And a big part of the integration is to integrate mental health services within physical health services. And I was just at a meeting 2 days ago in Colorado. We now have about 32 of these integrated med-psych programs going in our state. The one that I'm most familiar with is the one in our child clinic where we train pediatric residents to do outpatient care for their patients. But I will say it's a very exciting time because I think it allows us to give more holistic care for families. For one thing, it cuts down some of the stigma and the referral biases and barriers. And what I'm most excited about as a child psychiatrist is that if we can pick up these problems earlier, we can intervene earlier and really turn a trajectory around quite quickly. So I was in that clinic and saw a very difficult 4-year-old boy who was obstinate and out of control and yelling and had been fired or asked to leave about 4 preschools by the time I saw him. His mother was a single mom beside herself, had lots of problems. We picked that up in a well-child check that she was upset about this. We were able to engage with her in some parent training. We actually referred her quickly to an early mental health program at our mental health center. And when I saw that boy 6 months later, I would never have believed it was the same child. He was doing remarkably better. And I think of all the family therapists I know who are very wise and who have incredible skill sets and who could help not only the kids in these families but the parents. But typically family therapists are not connected with primary care settings. And I'm hoping they can be connected with these medical homes. And I think one of the ways to get family therapists involved, if they'd like to be involved, is to teach primary care physicians and other healthcare providers, nurses, PAs, etc., how to screen for parent-child relational problems, how to screen for child maltreatment, how to screen for intimate partner distress or intimate partner violence. And if that gets screened at a primary care level, it will only happen if the primary care providers know they have somebody they can trust that they can quickly refer the child or family to for treatment, because there's nothing that healthcare providers hate worse than identifying a problem that they don't know what to do with. So I really think this is a great opportunity for family therapists to be much more involved with many more families and at an earlier stage in the problem so that we can really help in this new healthcare system that hopefully we'll be all building together. Screening tools that are helpful for this, I will just mention again in that book that we have published, all of the screening tools and structured interviews are in the appendices of that book, and I would recommend if you have questions about how to do this in a primary care setting, if you're consulting to a pediatrician's office or a family physician's office, you might use some of the screening measures that are noted there. And I will want to say that we were able to get about 2/3 of what we had hoped to get into DSM-5. So we were able to get better descriptions of the parent-child relationship disorder or problem, as well as some of these other disorders into DSM-5, but we were not able to get all the criteria we wanted or as stringent as we wanted. However, the World Health Organization sponsors the ICD system, which the rest of the world uses, and they were very excited about this work because they are very excited about decreasing interpersonal violence within the home, both between adults and children, and have done some nice prevalence work in about 40 countries across the world of violence towards women in the home, and found that one of their biggest difficulties was that it was measured in very different ways in different countries, and so it was hard to compare one country to another. For their purposes, they think picking up violence in particular, but also relational problems, is one way to identify families at risk much earlier on and to intervene in relationships as a way to decrease both the physical and mental health burden of the world, particularly in lower income countries. So they are currently doing a field trial that has our more rigorous definitions not only of the parent-child relational problem but also of all the other relational problems we worked on, which were child maltreatment codes, intimate partner distress, and intimate partner violence. And if you want to participate, anybody who is a clinician can participate by going to that website and signing up. So they will give you instructions on how to get involved. The field trial involves getting emails and then doing an internet-based assessment of a vignette. And each assessment takes about 20 minutes. So it's something pretty exciting, but hopefully even better definitions of relational problems will get into the ICD-11 and be used worldwide. So if you have any questions, you can contact me at this email, but I think you can also contact me through our questions. So I think at this point, I've talked enough, and I'd love to hear from those of you in the audience. Thank you.
So that was wonderful, Marianne. You know what's so interesting? I have to say this. I didn't show this at the beginning, but this is the issue in which Marianne has a special section that she has edited that, you know, listed on the back. And there are 2 articles that she co-authored. But much of this information is a very helpful way to understand those articles. I'm just going to comment for a second. It might be easier, Jason, if you take Marianne off of presenter for a minute so they just get to see the 2 of us. There we go. There she is. More fun. So, because I didn't think you could see me. So I think you've made this very accessible to us by offering this information. It's available in your articles, but it's been so much more accessible through your slides. And people always ask if they can have a copy of the slides, and what some people have offered is a PDF copy. And I wondered if people want that, is that...
If I can figure out how to make it...
Would you make that available?
I'm happy to make it available. All the information and more in my slides is in the article and how I processed, but I'm certainly happy to make the slides available.
It is in the article. Yeah, It is in the article, but I can show you, or Jason can tell you how to make the PDF, and then if people request them, we can send them to them. The other thing I wanted to say before we get any questions and go any further is that in the special section, I'll show people how to do this later. In this special section, there are 5 articles, and then the editorial by Jay. And those will all be available to you to download for free for the next 30 days because of this webinar. So I will show you at the end of this how to do that. So I'm going to look and see if we have any questions coming in. I don't see any questions yet, so I'm hoping that they'll come in. I wanted to comment on something, Marianne, that I found interesting. I worked with David Reese briefly when I did my doctoral dissertation a million years ago, and then I'm remembering a presentation he gave at APTA about 10 years ago, and what I remember about that is he was talking about the genetic component of many behavioral disorders, and that even though there's this research that shows they're genetically determined, they can be overridden by the environmental context. But what I found interesting in your conversation, as you said, it's more likely to be overridden for the internalizing disorders than for the externalizing disorders. Is that correct? Did I hear that correctly?
I don't know if that's what I said. It's difficult to override it for the externalizing disorders because they tend to be more heritable, and maybe that's what you heard. That the heritability for conduct disorder is about 80%, and heritability for anxiety and depression disorders varies widely, but is more 30 to 50% depending on the age and the gender of the child. So there's probably more room in the environment to wiggle with the internalizing disorders than the externalizing disorders. But, you know, if you think about...
Well, one of the reasons I asked is because, yeah, I think my asking had to do with, as family therapists, you know, we're working with the context, right? And so we need to know what impact is possible and available. And I think that's really important.
Oh, I think so, exactly. And, you know,
I have a question from the attendee.
Okay.
So here's the question. It says, "Hi, Dr. Wamboldt. Thank you for your presentation. I believe you said that more than 60% of the children in the sample lived with both parents, and that the focus was on caregiver parent-child dyads. I'm just curious as to whether triads and the impact of the couple dynamic in the parent-child relationship was considered as part of the..."
You know, you are eons ahead of where DSM-5 would ever get to, and I totally agree. I think we were not able to assess the triad. We were happy to just try to get a dyadic relationship into DSM-5. However, there is a code in the V code section that is now a code for child affected by interparental conflict. And that's one we don't have criteria for it, but you can use it as a descriptor code, and there is really good evidence that children, for example, with parents who are having an acrimonious divorce, children do suffer from that. We were not able to get that level of detail in this particular study, and in fact, when our clinicians said we think the rate is more like 75%, they often thought it was the other parent that the child might be having a relational problem with, not the parent that brought them into the study. So if that makes sense. But we weren't able to assess all that within the confines of the study.
Yeah, that's taking it another step, isn't it? It's taking it another large leap. So I'm waiting for other questions to come in, so I'm sort of commenting on the things that I found interesting. Your slide that showed the correlation, which I thought was really interesting, between the relational diagnosis and those other more individualizing diagnoses. This is on page 41. This is the disruptive mood dysregulation, and the conduct disorder showed a significant correlation, which I thought was really interesting. And I think that's really important in terms of this research. Oh, I think you would agree with it.
I would totally agree with you, and it gives me even more respect for those wonderful people out at the Oregon Social Learning Center who've done such nice work trying to prevent kids developing conduct disorder. And for those of you who've seen that work, Patterson and Fogach, etc., those are hard families to help move because they all have that genetic bent to be more externalizing, impulsive, aggressive, etc., controlling. And so to help them tweak, but the beauty of it is if they just tweak their behavior a little, if the parents can tweak their own behavior a little, the trajectory for those kids improves so much more. So rather than escalating, it levels off or even declines over time.
So that reminds me of the other thing I was interested in, and that was the epigenetic information you were talking about with the mice. I love that story. So that you can turn the gene on, and so I'm thinking, are we thinking, I'm trying to generalize from what you were saying, that let's say a parent with a child with a conduct disorder changes a bit the way they relate to that child. Will that turn a gene on for that child for future parenting?
That would be the hope, and that's where I'm hoping science will look. But I would guess it either turns something on or it turns something off, and then that child has it in their genome, and when they parent, their child will get a little bit less. So if you can think about a gene that predicts for aggression, let's say, and better parenting moderates that gene, it turns it off or it decreases its ability to code for proteins, then that child will inherit that. So then the teenager, when they become a parent, their child will inherit a turned off gene as opposed to a turned on gene. So they may be less aggressive in that generation. And I think it could give support to this multi-generational work that a lot of family therapists do, is that if each generation modulates it a little bit, pretty soon it's out of the family. And so I'm thinking of some of Bowen's work. I just heard Judith Landau talking about substance abuse, a multi-generational perspective on how do you intervene with families who have substance abuse. And it's beautiful, that you can actually lessen the risk in further generations if you take that kind of an approach.
Yeah, I think that's really important for us to think about myself. I like that idea. I'll read you another question that came in, a comment. I actually was going to ask you about this myself. She said, you comment on what you mentioned about your findings with the Hispanic parent-child relationship.
Yes, when I presented that here locally, so I'll give you what the discussion was at our grand rounds locally. Some people thought it was that potentially in Colorado, in the families we see in Colorado, that the Latino families do have a generally more positive, warmer focus on parent-child relationships, and that that might be representative of that culture, that they truly might have less difficulties. Other people thought it might be that Hispanics in our culture here in Denver might be more likely to tell you the good news or present a good picture of their family and less likely to talk about what the problems are. And so, first of all, David Reese, who is a very good friend of mine, used to say the most interesting findings in psychosocial research are never replicated. And so I wouldn't make too much of this finding until it's replicated or somebody else replicates it. And I could see it go both ways. It could very well be that in that culture there's less conflict, there's less difficulty, more amenable parenting. I would hazard to guess that depends on how acculturated the families are to our Western culture. So my prior work in asthma showed that coming from Mexico was very protective. Children who were first generation in America from Mexico had low rates of asthma, but their rates of asthma increased as the family got more acculturated to our Western culture. So I think you'd have to look at all sorts of things to replicate this, including how acculturated does the family identify as being. But I think it was a really interesting finding, even though I won't say too much more about it.
Well, as you said, it's a very small sample, and I love David Reese's remark. It's we need to work to see it replicated. What I'm reminded of is our last webinar, I'm just going to remind people, was with Celia Falico. This is her book. And I think there's so many interesting things that she says about Latino families that, if you're interested in pursuing that, I would go read her book, too. It would be really helpful.
Yeah.
Here's a new question.
Okay.
Go ahead. The new question is, I'm a graduate student in couple family therapy at Drexel. I'm excited about the study and to learn more. In seeing this approach, how do I remain culturally sensitive in its application? Many medical models do not consider this. Thank you in advance, she says.
Yeah. You raise a very good question. And, what we put in there is it does need to be culturally sensitive and developmentally sensitive. So for children, that makes this a very challenging idea, is how do you get one construct that can serve across many different cultures, and not just within our country. And if you're interested in a very interesting look at child rearing, read Jared Diamond's most recent book, where he looks at parenting practices in indigenous cultures, and it's fascinating how different the approaches are, and yet how adaptable they are for the environments in which those families live. I mean, everything from a New Guinea tribal culture where they let children pretty much do what they want, so that many young children would crawl into fires and get burned because they believed that natural consequences was the best way to teach them to stay away from dangers in their pretty dangerous environment, to cultures where there was never any correction of the children and lots of warmth and lots of support for them. So I don't think there's one right way to do this, and I think the clinician needs to be smart enough and sensitive enough to understand the culture that the family is in order to make this call. There's a good example in the literature that what might be considered overprotective, as I was saying at the beginning, in a suburban culture for monitoring a child, not letting them play out, a 12-year-old child playing on the street is not a big deal if you live in a very safe neighborhood. It's a very big deal if you live in an unsafe neighborhood. And there's good data that urban black families in particular, the better families, are more overprotective and restrictive. They don't let their kids out on the street without being supervised because they're afraid that they're going to get involved with some kind of legitimate trouble. And so in that context, you could not code that as overprotective. In the other context, you might. So I don't know that there's an easy answer to that, but I think it's a wonderful question and a point well taken.
Well, it requires research at very small levels. You have to do it with this particular culture and that particular culture and that particular geography and that particular environment. So I love Jared Diamond's work, so I'll have to read that book.
Yeah,
it's very good.
I teach.
So here's another question.
Well, you're going to ask me the name of the book. I'll have to pull the chapter out to remember. But I teach child development, and I have them read his chapter on child rearing just to show that there are very many ways that cultures have chosen to raise their children, and most of them work pretty well, but they can be very different, so you have to be very attuned to the norms in that culture. I think the World Health Organization is really taking on a big challenge with this field trial, because they want to say that at least at the level of maltreatment, of physical violence, sexual violence, psychological violence, they want to make a worldwide standard. So I think that is a huge challenge and a huge, wonderful dream. If you can think, some cultures, as we know, condone burning of women when their husbands die, or they condone all sorts of horrible abuses of women and children, and it's the norm in their culture. I think the rates of some of their studies were 60% of women in some countries have been physically harmed by their intimate partners. So if they come out, and that's one benefit of this, if we say it doesn't matter the norm in your society, harming somebody physically or sexually is really abnormal and it's a problem, that could be a huge push for cultural change in some of these other cultures. So it goes both ways. You want to be culturally attuned, but sometimes the culture really is doing things that are not healthy, that are going to lead to mental and physical health problems.
Yeah. A new question, a different question. The person says, thank you, Marianne, for the presentation. What comments did clinicians or you make about the ways in which the assessment instruments also functioned as a clinical intervention? For example, families are given a language for describing their parent-child experience.
We have some bright people listening in today. That's an excellent question. And in fact, many of the trainees commented to me that just doing because they participated in both the DSM assessments, where it's a little bit more checklist, question and answer, do you have this, do you have that? And then they also did these family assessments with the parent and child, and they said they enjoyed doing the family assessment much more. And the parent and child often said, this felt so much better. It feels like we're actually getting a benefit from this. So yes, just asking about the patterns and discussing it with parents and children was very therapeutic, I think, and much more therapeutic than the traditional checklist DSM-5 kind of diagnosis. So good point. Yeah, we had a lot of comments about that, and some families actually wrote that on their, we got feedback from the families as well, and they would write that on their forms.
Another question, would you comment on the role of medication in this relational model?
I would love to comment on the role of medication. I see myself actually as both as a systems thinker, and that means at all levels. So at the social level, interpersonal level, but also at the biological level. And sometimes the best intervention, or one of our good interventions, is to add medication to somebody in the family. So I'll give you two examples. I trained under Carl Whitaker and Al Gurman, just so you know my family systems heritage, and I remember thinking, ADHD, this is just a problem with the parents and the child. If we could just teach parents how to parent better, these kids would not look so out of control. We pulled up an article where somebody looked at parenting interactions with a child who had ADHD when the child was on a stimulant versus when the child was off a stimulant, and parenting interactions, surprisingly, looked really good when the child was on a stimulant. They looked really bad when the child was off a stimulant. So it's a very complex interaction, but it's hard. Sometimes, I'm speaking as a child psychiatrist, so I'll pick on the child right now. Some kids are really hard to parent. If they're irritable, if they're hyperactive, if they're constantly getting in trouble, it would take a saint to never lose their patience or get irritable back, and yet doing that is going to make that child's self-esteem go down, but also their behavior worsen. So if you can not go overboard on medication, if you can still say the relationship is important, but this medication is going to help modulate, why not? I'm here to try to help kids, and believe me, kids need our help, and they're not that easy to treat sometimes. So I use whatever tool I can. Another example, a flip side of that, is I treated a lot of children with asthma in my prior life, and one of the best predictors of which child's asthma is not going to be well managed is whether there's a parent with major depression in the family. That managing a physical illness like asthma takes a lot of coordination, a lot of communication, and a lot of attention. And if a parent is depressed, they're not able to do that. They're not able to manage all those needs, and the child's medical illness also can get worse. So there actually is several studies done. Treating the depressed parent with an antidepressant improves the outcome of the child's asthma. So I think it goes both ways. I think if we had all the answers with therapy, I would be very happy. If we had all the answers with medication, I'd be happy. I don't think either has all the answers. I think we have to use every tool we can when we treat kids, at least.
So I did not know you had, I knew you had a relationship with Al Gurman. I did not know you had studied with Carl Whitaker. Maybe this is off of your presentation, but I think it may be interesting to our audience. And how it is that you have a family therapy training along with being a child psychiatrist. How did that happen?
Well, I was very fortunate to be trained at the University of Wisconsin in Madison during the heyday of family therapy. Like Carl Whitaker was on our faculty, Al Gurman was on our faculty. We had a number of faculty members who practiced family therapy in addition to other areas of psychiatry. And we trained not just in a co-location model, but in a very integrated model with psychology interns. So Nadine Kaslow was one of the psychology interns when I was a resident. And in fact, I think one of my first papers I wrote with Nadine. So I think having that rich interplay of training really helped that work. It was also at a time when family medicine was very excited about dealing with families and doing family therapy within a family medicine context. And the family medicine department at Wisconsin was also very strong, and we had a lot of interactions back and forth. So actually treating families in primary care clinics was not unusual for the training. So I think that's where I really got steeped in family relations. Then I went to NIMH. I was actually the first, I hate to say this, but I was the first postdoc of Tom Insel. And I wanted to study family systems in a monkey model. So we were actually studying marmoset, which are tiny, tiny little primates. Pygmy marmosets are some of the smallest primates in the world, but they live in family groups. And they always have 2 offspring with each birth. And the first set of offspring have to stay through and co-parent the second set of offspring in order for their parenting behaviors to get consolidated, if that makes sense. So the family groups would often be the 2 parents, older adolescents, if you will, and then the newborn little babies. And if the older adolescents were pulled from the family group before they co-parented the little babies, they were very bad parents when they had their own offspring. So again, it was a really wonderful model. Now, if I were interested in the technology, I bet we could look at genes that get methylated or not during that process. But so anyway, but that's where I also got entrenched in the biology of things and away from the relational. But I still think with both mindsets.
Yeah, and it's in my mind, in my experience, in my opinion, it's a wonderful combination. It's delightful. You bring so much richness to the conversation. So we have about 10 minutes left. What I want to do, so we don't run out of time, is show people how to access your articles. So maybe, Jason, if you'd make me the presenter at least to do that. And then I will, let's see, show my screen. And I will show my screen. There we go. So for those of you who don't know, this is the Family Process Wiley Online Library homepage. And the way you could get to that, I'm going to show you how to do that, is on your own browser. Just type in, I'm showing you how to do that, Family Process. That will bring up, it's going to bring it up. It's going to do it in a minute because my internet is really slow this morning. There it is. It will bring up several different family process. What you want is Family Process Wiley Online Library. On my particular list is the 4th one. So I'll click on that, and it actually goes back to the page I was just on, which I think I will just do this way because it might be quicker. Well, maybe not. It's very to have a slow internet when you're trying to do a webinar. So here's the Wiley Online Library Family Process homepage, loading slowly. And As soon as it loads, I will show you what is on there. Marianne's article, one of her 2 articles, is actually the featured article for this issue, which means that that's available to also to download for free. And here we go. So see her smiling face, the description of relational processes, recent changes, and she's also done a video abstract for that. And you can click on that, or you can click on the Family Process homepage channel. I will show you how to get to that too in just a second. What I want to show you how you can access the article for free. Go to the current issue, which is March 2015, and that's you see I just clicked on that, and what will come up eventually are the articles for the current issue. And as soon as those come up on maybe your computer faster than they are on mine, you'll see that they're unlocked. So they're all unlocked on mine because I'm a subscriber. But edited by Marianne Wamboldt, there's 1, 2, 3, 4, 5 articles. And those articles are available to be downloaded for free. Marianne has a video abstract for both of hers. And this article on intimate partner relationship distress in the DSM-5 has been translated in Spanish and Simple Chinese, which is one of the features we offer through Family Process, which I think is wonderful for us to have that those possibilities for people. I'm going back to the home page, I think, as soon as I can. And what I want to show you is how you can access the Family Process 1 YouTube channel. And one of the reasons I want to show you that is not only so that you can see Marianne's video abstract, but also to know that all of our webinars, including this one, are available on our Family Process 1 YouTube channel. All you would need to do is go to YouTube, type in Family Process 1, and what will come up is our YouTube channel. And what I do is, what I would recommend you do is go to our playlists. Here's our playlist here. I'm trying to go to further ones, move it on. So here's Marianne again with her March 2015 video. So the playlist here on the side, you go to hashtag FPI webinars, and you will have available all the webinars we have done, including Foma Walsh's, which was our first one, Celia Falco's Multidimensional Framework for Culturally and Socially Responsive Practices, 50 Shades of Gender, which John Malpaul did, which was wonderful. The Professional is the Political by Kata Weingarten, again, they're all been wonderful. The Strengths Framework for Family-Centered Services with Bill Madsen, and Sequin Families and Family Press with Evan Ember Black. So you can take me off presenter if you want to, Jason, and I'll come back and talk to Marianne. So that's what we have available, and I think that we have all that available for you folks to access. So I'm back, Marianne, and you're back. Do you have anything more you want to add to what I just said, Marianne? Anything you want to say about the Family Process Institute or about the journal?
I will say the Family Process Institute is growing and moving, in part because the journal is doing so well with all of your support as both readers and as submitters of articles. But because we have been successful, the Institute is actually trying to figure out ways to disseminate information about family therapy and family processes to help educate people, provide other kinds of research potentially that might be more clinically usable. So if you look at our other website, which you'd have to type in Family Process Institute now, it will tell you about some of our programs. So the webinars are one of the things that we are offering to kind of reach people like me, actually, who prefer to hear somebody talk than read an article sometime. We also offer at times a new writers workshop for graduate students or junior faculty who are working on getting a manuscript published and would like some expertise in writing skills for our journal or for other journals. We have a small grants program, and we're open to ideas. So the same contact information or through our website, if you have ideas about ways that we as an institute can promote our field, not only in our country but across the world, let us know. We're really interested to find out. But we really see ourselves as kind of a trading station where information can be shared and traded and promoted and gotten out to more people.
We also have an international grants initiative that's started up?
We do. We have an international group, and a lot of what we've been doing with that is providing workshops in Latin America and Mexico to family therapy institutes or clinical training programs, both to help people write up their ideas and their work so that it could be publishable in a journal such as ours, but also just to promote more scholarship in family therapy.
Mm-hmm. Well, it's pretty exciting. It's very exciting to be involved with this group at this time in my life. So I encourage people to learn more about Family Process and about the Institute. I think it's just familyprocess.org to get to the Institute website. So Marianne, anything else you want to add about your presentation? Any last words for our audience before they disappear?
Before they disappear? Well, I'd love input because I know this is just a first stab at creating criteria. So if people have thoughtful things that they think we need to add or things we should delete, I'd really love to hear that. And I also really want to encourage people to think about working with primary care settings and these new medical homes, because I think family therapy has so much to offer, and the need is great. And I think when we stay in our own isolated mental health spheres, many people don't get to benefit from what we can offer, and I think it's exciting to work with primary care docs. So
that's a great suggestion, Marianne. I love that. It's a great suggestion. I just want to remind everyone we are sending out a follow-up survey. It's very short, but we'd like you to respond to it. We're collecting more and more information, and look for our hashtag Family Process Institute webinars, and you'll see Marianne on a webcast if you want to, if you missed any of this today. Marianne, thank you so much for offering this. It was delightful. I couldn't imagine you would be anything but an excellent presenter, and you are. So I'm going to see you in just a week, which is pretty cool.
Yes, and we'll get to talk about this. Thank you, Vicki, and thanks, Jason, for your support. Okay, bye-bye, everybody.